We're going to call order the meeting for the Health Insurance and Long-Term Care Issue Committee. We will not take a roll. We'll mark everybody attendance present. Good afternoon. I'm West Virginia Delegate Steve Westfall, and I'll be the chair of the committee today. I need a motion to waive a quorum.
So moved.
Second? Second? All in favor say aye. All opposed nays. Quorum is waived. Also need a motion to approve the March 12th, 2023, May 19th, 2023 committee minutes. There's a so moved. Second? Second. All in favor say aye. All opposed nay. Minutes are approved. Okay, today our first presentation is a new at-home addiction treatment program. Joining us today is Dr. Brian Holzer, President and CEO of Aware Recovery Care. Dr. Holzer, if you go right ahead.
Thank you very much. I appreciate the time. In the interest of time, let me just dive right in here. I am the CEO of a company called Aware Recovery Care. I think the print's a little small. But we are the country's only scaled in-home addiction treatment company. And what that means is we're actually sending real people in a people-first, in-home first care model. We have no facilities. We have no treatment centers. Our treatment center is the home of the client that we're treating. And the program is delivered in 4 phases over a 12-month period of time. So we're sending care teams into the home over a 12-month period of time. And that allows us the time and opportunity to peel back the onion and address over a period of time the source traumas, the environmental conditions, in many cases the family is in crisis, and so we have dedicated staff working with the family, and I use the word family loosely to mean friends, allies, constituents, and supporters. And so through that period of time, you're able to repair the family relationships, ultimately creating strength around a platform of recovery, dive into source traumas that in many cases are contributing to the addiction, and ultimately repair and create a foundation for sustained recovery. Again, the print is small, so I'm ad-libbing here, but if you look at the state map, you'll see that in the darker color, those are the states that we're in. It's worth noting that this company was founded in 2011 in the state of Connecticut. As of 2016, 7 years ago, the company had 50 employees and 100 clients in the Connecticut area, all being treated in a fee-for-service situation. In 2016, Anthem of Connecticut came to the table, and we were able to negotiate a bundled payment rate so that we receive a bundled payment on a monthly basis for the totality of our services. For the client, what that means is a single copay rather than individual copays for the various fee-for-service services that they would be receiving in order to receive the totality of our care model. So 7 years ago, 50 employees, 100 clients, 1 state. We are now 900 employees, 11 states. We've treated over 7,000 clients in the last 3 years alone. We have 16 bundled payment contracts with various commercial insurers only to support this, and we have about 1,800 clients on census. I'll quickly note, because my background is actually traditional home health care, certified home health. This is not home health care. For those of you familiar with traditional home health care, that is a nurse-therapist model, which essentially you're sending a nurse and a therapist, and it's carefully considered in that the acuity of the patient defines how many visits. And I'm a big fan of home health, but the reality is those models make the most sense financially when visits are rationed. When you look at our model on the right, you see a total whole person approach to the care team model, and because we're in a bundled payment arrangement, we're able to deliver the right amount of services customized to the needs of the client over an extended period of time. You'll see, again, the print is small, but there's 3 parts to the wheel. There's a client-focused component to our care teams. We have both peer coaches, family educators, and therapists dedicated to the client. In the yellow, we have a family-focused track to our program in which each family is assigned a family education facilitator, and then we broker family systems therapy to begin working on the repair of the family unit. All of this is underpinned in medical oversight, in which we have an addiction psychiatrist that is involved in the care team meetings, a health service systems director, and a nurse practitioner that will provide bridge medication and ongoing MAT services. You may have seen the proliferation of MAT and e-prescribing going on in this space. That is not our business model. That is a feature of our model. This is an integrated care model that provides continuation between the prescribing of medications, brokered and overseen by real people delivering the care, which we believe is a much more effective model. Though e-prescribing is, again, something I'm very pro and something that's very important in this particular segment. So what you're looking at is a medical, behavioral, and psychosocial approach to care. Again, I have not seen this. I've been in healthcare my entire career. I have never seen a model that provides this amount of services over an extended period of time, really breaking down the barriers and providing a sustained approach to addiction recovery. I also don't think this should be specific to addiction. As a side note, this is, in my view, the way we should be approaching all chronic diseases. We have a sick care system that ultimately chooses to stabilize. We don't have a system in healthcare that chooses to repair and create a foundation to allow for sustained recovery. On the ASAM scoring scale, for those that are familiar, and I'll just sort of take away those fancy terms and say that this is a lower acuity residential model all the way down to an outpatient model. 2/3 of our clients are actually coming from residential treatment. So ultimately, because our residential treatment programs in our country are really about stabilizing, not necessarily creating sobriety, much like post-acute, which is my background. We stabilize in hospitals, then we kick them out too early, and then we rely on disconnected fee-for-service entities to try and work together, which they don't, to create a continuous care model post-hospitalization. As I shifted to addiction, I saw the same darn thing. We've got, instead of hospitals, we got residential treatment programs. Then we have all different levels of care that are not connected. And we rely on someone in crisis to navigate those levels. And in addiction, there's periods of disengagement and engagement. People go up and down in the acuity scale, and there's no one there to hold their hand through the levels of care. AWARE was grounded and founded on the concept of creating a 12-month integrated care program to allow someone to flow through those levels of care from lower intensity residential all the way through outpatient. Again, the print is small, but we actually aim for 150 total visits over a 12-month period of time. The color is essentially mapped to the types of resources that are available and the cadence that go into the home. Without worrying about all the words, essentially what you're looking at is each client will be assigned 2 peer coaches and 1 care coordinator that will be a nurse or a social worker on the first home visit. The peer coaches are designed to alternate and be in the home twice a week for all 52 weeks. The nurses will provide virtual support every 4 weeks. Family therapy for the client will start very early in the phases. Family systems therapy will roll in, and all of this is grounded in medical oversight from an addiction psychiatrist and nurse practitioner. In the interest of time, let me skip to some outcomes. First, our outcomes are a reflection of our payer contracts. We are not in Medicaid at this point in time. We are all commercial, and you can see the logos at the bottom in terms of the commercial insurers that support our operations in the 11 states. We essentially contract with an insurance company with those bundled rates before we enter a state. We entered the great state of Kentucky in December, and Georgia in the Atlanta area this past month. We'll be entering the New York area as our 12th state early next year. We aim to get into the Medicaid side of the equation. It's a more complicated segment because the pressures on the actual bundle will be real. And we think, though, that there's an opportunity through shared upside on sort of a total PMPM savings basis, given the amount of savings that we deliver, that there's an opportunity to make the model work on the Medicaid side as well. From an outcomes basis, you're not going to see anything like this, not only in addiction, but anywhere in healthcare. At least I haven't seen anything close to it. The average length of stay is 250 days. You can see the retention rates, and this is not just someone answering a phone or a telemedicine app. They continue to welcome us into their home. 2/3 of the clients are with us at 6 months, and a full, almost 50% of the clients complete the full 12-month program. That data is encompassing those that will complete the program early because they reach their treatment goals. And so our goal is not to drive length of utilization. Our goal is to drive outcomes and meeting of treatment goals. In terms of data, this is actually not our data. This is Elevance data, Elevance Health data. Those of you unfamiliar with the branding changes, AKA Anthem, AKA Carillon, AKA Beacon. But it's now, the umbrella brand is called Elevance Health. Skipping to sort of the right is a expression of our outcomes on a per member per month basis, which is a merge of both medical and behavioral impacts. The medical impacts are driven by inpatient and ED reductions. And the behavioral impacts are measured by partial hospitalization days and intensive outpatient days, PHP, IOP. What you see is during the year, if you look at the left first, during the year that they're on our program, those are the reductions in PMPM savings compared to the cohort before they started our program. It takes a look at about 300 clients. What were their costs, both medical and behavioral, prior to starting? What were their cost reductions during the program? And even the year after they're off our program, what were the cost reductions? There is a tail on this program, which I've never seen in healthcare. Usually things work while you're doing something. You remove that something, they tend to regress to the mean. Here, it sustains. And when you convert it to the PMPMs on the right, again, the numbers are small, we have a 50% medical PMPM reduction the year that they're on a program. They're simply using less inpatient and ED care because we're resolving what causes a lot of that, which is the behavioral condition. When we stop our services and they complete the program, you are still seeing a tail of 60% plus reduction in behavioral PMPM spend. Never seen it. Why? Because we're creating an environment for sustained recovery, and ultimately, if they're seeking care, it will be outpatient or not at all. This is just a slide showing our Medicaid experience in a pilot in New Hampshire. If you looked at the slide before in this one, you'd see that our medical PMPM savings are actually better. That's all I have, and I'm happy to answer any questions.
Do you have any questions? No questions?
Yes.
I have a question.
Okay.
Thank you. I appreciate your presentation. I think this is really exciting, and I appreciate the time that you and I have had to speak about this. Am I correct in assuming that part of the reason you're here is because you're looking for more insurance partners in this realm? If you could speak to that a little bit. And then my second question is I was impressed that you are not seeing provider shortages. So can you actually also speak to some of the success on the provider profession side of this as well?
Appreciate the questions. Yes, so the challenge with this model is it's new, and new things in healthcare take time. And again, to be a bit of a naysayer, we talk a lot about the shift to value, and I think we're a lot further away from that than we like to talk about us being, because in order to create a value-based healthcare model, you need participation and partnership between providers and payers. And risk-based reimbursement and payment models require data and partnership between providers and payers. Our ability to get towards a bundled type model is one giant step towards a full sort of value-based, risk-based model where we can put a % of the bundle at risk, deliver outcomes, and receive further upside based on impacts on PMPM savings. Anthem has been to date the only insurer that sort of has leaned into this on the commercial side in a big way and has recently become an investor. We have had less success with some of the other large commercial insurers simply because when you look at our costs, which are about $40,000 over the course of a full year, it appears to be sticker shock because most, and I've worked for insurance companies, they tend to look at sort of the ability to control for costs in a finite period of time and don't like necessarily long-term utilization expense for which this is. It's a shift in mindset, but it's a shift towards exactly where we all want to go or where we're stated to go in terms of payment models. I would certainly support, in the states that we're in and states that we're not in, the ability for members here to facilitate introductions and meetings with representatives from large commercial health insurance companies. This needs to be in more homes in more states. The reality is we are not disrupting. We're adding a new level of care, providing more access in a form in which does not exist today. The ability for people to continue working, go to school, not have to worry about childcare responsibilities. We come to the home and schedule our visits around the needs of clients. This has got a great application to labor and trade. They don't get paid unless they work, and the labor employer does not enjoy turnover. This has got a very significant impact to employers from the standpoint of alleviating the need for FMLA and allowing the workers to continue receiving treatment while working. And so I would certainly appreciate any help and guidance with regards to more connections with more commercial insurers, executives, so that we can get this into the hands, into the homes of more clients. From a provider standpoint, we hire locally. If your definition of provider is actually our care team providers. 80% of our 900 employees are in recovery themselves. Our company becomes a place of therapy for actually our employees as well. They are in their recovery journey, and this helps them because they're helping others. We are an employer of difficult to employ or impossible to employ people, in that we will hire folks with felony convictions, previous incarceration, no bachelor's degree. We provide tracks for people to essentially get upskilled and have career pathways. From a provider standpoint, we help the communities in terms of growing jobs and ultimately those jobs of being people that are transitioning from not being employed or being difficult to employ. If that answers your question.
Any more questions? Seeing, we do. Go ahead. I can't see your name from here.
Great, thank you. So, two questions about your model. One, when you reference visits, do those include telemedicine visits? And then the second one, when you referenced about IOP and PHP days, those are typically functions performed in a group setting.
Yes.
Does your company have your own provision of that, or what is the linkage between other services and the cost associated with that also?
Yeah, we're transitioning a bit on the in-person versus virtual. COVID taught us that virtual does work. Prior to COVID, this was almost 100% of the care was delivered in the home across all the resources. The shift is going to be, our peer coach model is designed to be in the home. That is the tip of our spear, and you're ultimately sending someone into the home that was previously in addiction and has sort of walked the walk. And when you send someone in that has been, was the client, that immediately sort of takes the veil out of the, off of sort of the friction of a white coat going into a home or a nurse that hasn't been through what they've been through. They know all the tricks. They know that the alcohol in the shampoo bottle is not something to be ashamed about because they did the same thing. And so the peer coaches in the home will stay in the home. We are relying on more virtual connectivity with our other care team supports, the nurses, the social workers, because a lot of what they do will be the care coordination work, making sure they have their follow-up physician visits. They have access to whatever they need in terms of their medical care. And so the answer to your question is almost 100% of the peer coach work will be in the home, maybe 75 to 100%, and then a lot of the other work will be virtual. The second part of your question?
The PHP and the
Yes.
IOP, so how is that integrated?
Yeah, and again, just in the interest of time, I'll be brief. I'm not in recovery, but I'm surrounded by people that are, and so I learn from them every day. What I have been told is that group therapy ends up being an inhibitor for many people to seek treatment, particularly under the commercial insured professional side of the equation, in that it's very difficult for someone to raise their hand in a group setting of strangers and say, I have a problem. And so it keeps people actually from seeking treatment. Ultimately, what ends up happening is we work with PHP and IOP. We'll be the tail on a PHP stay, and there is the ability for us to co-treat people that are receiving therapy with IOP and also our in-home care model. What ends up happening is folks resolve from their active addiction towards the later part of our stages. People realize that they need help and be surrounded by people who have gone through the same thing. They become a little bit more open to group therapy, and we will facilitate the interactions with AA, NA, various therapists if they don't have one. So we sort of work through that initial stage where our program allows them to receive treatment confidentially, to when if they want group therapy, we will help facilitate that, because our goal is when we wind down, we've left them with the connectivity in their communities that will allow for lifelong sobriety.
Okay, we have one more question.
Okay.
Go ahead.
Hi, I wanted to know, does your program deal with or work with veterans with post-traumatic stress, and what kind of facilitation do you do with the VA?
We don't have a contract with the VA, would love one. And with regards to, again, segments of veterans as an example, we are working to employ more veterans, particularly those in recovery, because again, the model is predicated on sending someone in the home that looks and feels like the person we're trying to treat. I'm sure we have veterans on census. We don't have a dedicated approach to that at this point. We've been more focused on first responders. We've hired quite a few first responders, and ultimately try very hard to sort of gender story match our clients to the degree possible. And we have dedicated programs and relationships with various police associations, firefighters, and such in various states. Transition programs from incarceration. One of our first clients in Kentucky, I live in Louisville, was actually referred to by the police, because what we're trying to sort of hardwire in the communities, when a police goes to a call and they ultimately see someone that the worst place that they need to be is incarcerated, and what the real issue is addiction, we serve as a potential for that individual to alleviate the need for incarceration and ultimately seek the care they need in their home. And so these relationships with first responders, of where we've been very focused in the last couple of years, we would love to get more involved with veterans.
I think we do have one more. Yes, go ahead.
Hi, I'm Rep. Michelson Janae from Colorado. I'm curious about wages. Are you able to pay competitively for your people? And a question I'll ask you to answer later is, have you tried to work with Medicaid and it has just not worked yet?
Yeah, I've been here 14, 15 months. Medicaid was on the roadmap when I got here. It's now on the road. We don't have a Medicaid provider number at this point because we're looking for dance partners before we, jump into a bunch of states. We need to negotiate a new rate. We got to figure out the care model, and so on and so forth. We are very eager to bridge the gap into Medicaid. With our Anthem relationship, they are also eager, and so I think it's probably within the next 18 months we're going to have some pilots up and running on the Medicaid side. We pay more than anyone else in the industry, period, not even close, and that's by design. Our peer coaches currently are W-2. We're likely to move them to hourly with the ability to receive benefits if they work over 30 hours, so hourly, non-exempt. That hourly wage would translate to something 20% higher than anything else we've seen in the industry and some. We have a 401k, a company match. We offer benefits that are first in class, and so on and so forth. These peer coaches have been completely neglected, quite honestly, with all of the models that are starting to rely on them. $16 an hour, $14 an hour, this, that, and the other. We're into the low to mid-20s regards to an hourly wage. We want those folks, our peer coaches, to be competitively paid above anything else they could get anywhere else. It's the most important part of our program from the standpoint of creating that credibility.
Okay. Thank you,
Thank you
Dr.
very
Holmes,
much.
for being here. If you would stay around, I think some other people might have some questions afterward. We do have a pretty heavy agenda today. I'd like to talk to you also myself.
Okay. Appreciate the time.
Okay. Next on our agenda is continued discussion of the NCOIL Medical Loss Ratio for Dental Health Care Services Plan Model Act, a model which I'm sponsoring. You can view the model on the website and also in the binder on page 96. As you know, I sponsored similar legislation last year, but I'm going to wait to see what NCOIL does. I'm also glad that Illinois Representative Rita Mayfield has signed on as co-sponsor of the model, shows the bipartisan support. We have produced discussion on the model at our meeting past March in San Diego. I'm looking forward to continue work and get across the finish line either November or April. I'm certainly open to making any changes to the model. In fact, I know that we're hearing a different approach that some states have taken to respect to the issue today. There will not be any votes on the Model Act today, and we will hear our speakers determine the best to proceed. We hold all questions to the end till all our speakers are done. We will start off first with Michael Albert from the National Association of Dental Plans. So Michael, you go ahead.
Thank you, Delegate Westphal, President Ferguson. We appreciate the opportunity to speak with you today. So there's been a lot of time invested on NCOIL on this issue. We do appreciate it. We do want to remind you that dental and medical are, of course, very different in a number of ways, particularly beginning with one being a high premium product and one being a low premium product. We'd refer you to the NAIC's significant work in that area over the years. As you already know, for medical plans, there's been a required MLR since the passage of the Affordable Care Act. We'd also ask you to know that as part of the Affordable Care Act, there were a lot of provisions impacting health plans. Health plans ultimately supported, by and large, the Affordable Care Act. One of the reasons that they did was they received 30 million federally subsidized new lives. So when we talk about applying an MLR to the dental world, it's important to note that there is no great public policy trade-off here. We're simply talking about applying a new set of requirements. Delegate Westphal, you did note that a number of states have moved toward reporting and remediation requirements in the last couple of years. My colleague Owen will discuss that as well. I wanted to level set on where we are with dental benefits and make sure that the committee is aware of progress being made in dental benefits. First of all, dental premiums are barely rising, less than 1% a year over the last few years, and that compares very favorably to premium increases in medical and, of course, the inflation rate. Similarly, the question has come up, is there improved consumer protections built into dental plans? The answer to that is yes. We have positive trend lines in that direction. We note that the percentage of enrollees in plans with low deductibles has gone from 22% to 41%. This is among PPOs, but PPOs are 90% of the market. Similarly, the question of annual max has been discussed at prior meetings, and the question is, are annual maxes rising? Again, the answer is yes, and the percentage in plans with high annual maxes has gone up from 5% to 17% since 2017. Also, the dental insurance market generally has robust competition across the states, and competition, of course, holds down prices and also increases the leverage of providers in determining rates and who they want to do business with. Owen.
Great. Thank you, Mike. So next we wanted to take a little bit of time to go through some of the activity that we've seen since the March meeting and through 2023 as it relates to dental loss ratio bills that have been introduced in the states. So since we last spoke on this issue at the March meeting, so there have been 14 states this year that have introduced legislation related to dental loss ratios. Most of these bills originally in their form representing a similarity to the Massachusetts ballot initiative, which passed last year. In 9 of those 14 states, those bills were introduced and either did not move forward at all, they were not heard in committee, or they ended up not being signed by the end of their legislative session. So that's 9 of the 14. In 4 states, you saw compromise legislation or adjusted legislation passed, the first of which being Arizona, which started out as an 80% loss ratio requirement for every dental plan in the state. That ended up being a bill that included reporting requirements for dental plans in the state. In Colorado, which we'll touch on in just a second as well, there was a structure that included not only reporting, but additional requirements that outlier dental plans or plans that are outside of the norms for loss ratios within the state would have to conduct some form of remediation with the department. New Hampshire also passed a reporting structure for their dental loss ratios. And lastly, Nevada was a state that had a loss ratio included within their rate filing process, so it was a prospective loss ratio that they re-upped in a piece of legislation after it had been on the books for several decades as part of their rate filing process. And we still have one state left that's potentially thinking about DLR legislation this session at this point, and that's Pennsylvania, which introduced a reporting-only bill. So all of these bills that have ended up in different places we're trying to show as a little bit of a contrast to the loss ratio ballot initiative that passed in Massachusetts. So for those of you who may not have seen this ballot initiative, it set an 83% loss ratio for all dental plans within the state of Massachusetts. And in order for them to exist in the state, so that's not only in the large group market, that's also plans that are for individuals or in the small group market as well. They set that number across the board. Before this ballot initiative was passed, NADP worked with Milliman to get an analysis of what the impact of that ballot initiative would be on our members. And there were some concerns that we saw when we got that data back. And most in particular, the impact would be strongest in the small group market, where there was the potential in some circumstances for there to be an up to 38% increase in premiums. So we're talking about a 38% increase in premiums for plans that are being offered to small groups, small businesses in the under 50 size. and that any impact on any potential rebating, which is one of the kind of main structures of medical loss ratio under the ACA, most of the rebates that would be given out would be de minimis. They would be below ACA requirements for them to be issued. So there would be a lot of administrative activity that would be done, but at the end of the day, there would not be a significant return to the consumer for meeting that loss ratio. In some cases, there would be a concern that it would cost more to send out the rebate checks for the loss ratio than it would be to actually than it would be given to the individual. So since the ballot initiative is passed, we did that analysis and we've continued to monitor the situation. There have been significant difficulties in moving towards implementation of this loss ratio requirement. The Department of Insurance within Massachusetts continues to work on a proposed rule to implement the loss ratio, and we have seen, even before seeing that rule, that some of our members, these are national multi-line carriers that are in the small group space, that at least 2 of those carriers have decided to leave the market in Massachusetts, and we have not even gotten to the implementation. And one of our primary concerns heading into 2024 in Massachusetts with this loss ratio requirement is that we're going to continue to see that reduction in the competition, particularly within the small group space for dental plans. And as Mike pointed out earlier in his presentation, that is one of the things that keeps the dental benefits market in states robust, that you have a large amount of plans that are vying for these different groups and for the individual and small and large group markets. And if we saw a reduction in that competition, then the premium levels that have been kept well below inflation for the past 2 decades could potentially increase, as well as some of the impacts that we saw of the actual implementation of the loss ratio. So those are kind of the dueling concerns, the potential increase in premium and then also the potential for the loss of competition within the dental benefits market. And this is just a map to illustrate some of the activity that you can see on there. I'll point out as well, New Mexico also set a loss ratio for their plans at the end of 2022. That was through a regulatory process and not through legislation. They set a 65% loss ratio across the board after having essentially 2 decades of data from rate filings within that state, that they were able to look at that information and say that that number made sense. And this is where we think an alternative to the existing draft of the model comes in. So Maine, in 2022, passed LD 1266, which was a structure that allowed not only for the reporting of dental loss ratios for these plans, but also empowered the Department of Insurance to take remedial action against plans that were designated as statistical outliers. So you would have not only the reporting that's been in place in states like California or Washington for a number of years, but you would also have an additional enforcement capacity in those states that would be tailored to the data within those markets. So you would split out the measurements by the individual, the small group, and the large group markets, and then over a 3-year measurement period in order to determine validity, you would look and say, what are the outliers from these plans? And then the department would be able to go in and check those plans, conduct conditional financial examinations, or require them to adjust their premiums or do other forms of remediation. And this allows the department, as well as the people who pass the legislation, to kind of really get into the details of what is happening with these plans, why are their loss ratios outside of the normal bounds of the market, and what can we do to make sure that these plans present value to the people who are purchasing them. And we really think that the approach in Maine LD 1266 is something that gives them a direction for them to be able to take those actions while preserving the competitiveness that has kept the dental benefits market healthy. And we saw an example of this type of legislation being implemented in this past legislative session. Colorado passed SB 23-179. This was a bill that started out as an 80% loss ratio requirement, but after considerable discussions with the sponsor, who is the majority leader of the Senate, as well as with provider groups and consumer groups and the plans within the state, there was a consensus reached to adopt a reporting and outlier remediation structure that was signed into law on June 2nd. I will also point out that there were additional reporting requirements that were included in the Colorado bill that are not included within the Maine structure. This includes requirements that plans disclose how many people reach their out-of-pocket maximum every year, and then also what the average out-of-pocket maximum is for their plans in each market segment. So adding on some additional requirements to plans in order for them to report to the department, make that public, and then also empower their Department of Insurance to take those actions against outliers in the state. And if necessary, if the average loss ratio in each market segment is declining, then it also empowers the department to set a minimum floor based on that information. And now I'll turn it back to Mike.
Okay, thanks. So we ask you, as you consider this important issue, to think about unintended consequences. And a arbitrarily applied loss ratio that is not based on practices in that state is going to change dental plans in that state potentially very, very significantly. Dental plans are going to have to look at lowering their administrative costs potentially dramatically. When that happens, it's important to remember what is included in administrative costs. It's call centers for providers and for consumers. It's processing claims. It's maintaining broad networks. It's detecting fraud and abuse and a variety of other things that we consider to be very good expenses. The point here is that when you hear the word administrative cost, there's an assumption that it's just someone in an office somewhere with a stapler. These are vital operations and operations that make plans successful. It's also worth noting that consumer satisfaction with their dental plan, according to J.D. Power, which does national surveys, has increased. It's 18 points higher on a 1,000-point scale than it was last year. Owen also mentioned unintended consequences in the form of potential plan pullouts if it's an arbitrarily applied high number, and the loss of competition and consolidation that would result. Where do we go from here? We'd ask NCOIL to consider, first of all, that there are significant successes in the dental insurance market today. We're holding down premiums. We have significant competition. The margins being generated by dental plans are unremarkable and consistent with other lines of business. Having said that, if NCOIL believes a model is necessary, we do think that a reporting and remediation model, as a number of states have adopted and are considering adopted, is a vastly better approach than arbitrarily selecting a number that has no bearing in the existing practices in that state. And lastly, we would just ask you again to remember that because something is done in medical, a high premium product with a $600 a month premium does not mean that that automatically ports to a dental product with a $40 a month premium and many of the same fixed or quasi-fixed administrative costs. The NAIC has long recognized the need to treat low premium and high premium products differently. Thank you very much.
Okay. Next, we have Chad Olson, the Director of State Government Affairs from the American Dental Association.
Thank you so much, everybody. And I think I have a presentation. Is that correct? Yeah. All right, great. So my pleasure to talk with this body again. Again, I'm Chad Olson. I'm the Director of State Government Affairs for the American Dental Association. It's always a pleasure to talk to this body. And thank you to my colleagues or friends over from NADP that gave their presentation. I'm here today to convince you about what a good policy medical loss ratio is, with some additional ingredients to the ones identified by the National Association of Dental Plans. I'd like everybody to think about the fact that there has been an inflection point in dental plans, and it was the Massachusetts ballot initiative. I know it's uncomfortable for the dental plans to talk about, or maybe even it's uncomfortable to talk about it because it is an inflection point. They know that things have changed. The landscape could potentially change, and they would like things to stay in the status quo. but inertia has not worked in the favor of consumers. And when we talk about competition, which they did extensively, we have to focus on the fact of who is benefiting, keeping the premiums low. Who has it ultimately benefited? Who has value out of their products? I would argue that the patients do not get a value out of it. What we have from this competition, basically, is years and years of competition, is $1,000 is all, a limit, upper limit of $1,000 is all that an American should deserve or get. That's what this competition has resulted in. And I know that there was some discussion of maybe the annual limits are going up slightly, but the truth is that there are mechanisms built into dental plans that do not allow you to get benefits, major services for greater than 50%. That's built into the cake, and that's why most people don't reach their annual maximums. So how do we address dental plans in a way that focuses on the future? I like the last speaker, what he said, Mr. Holzer, about let's look at the trends and how we can impact a product so that it is more valuable to the people that matter the most, which are the patients. This is a pro-consumer initiative, so let me take you through my slide deck. Okay, what is medical loss ratio? I'm not sure if that was explained earlier. Just to be clear, it is setting a ratio that this is the amount of money that has to be spent on care, and the rest can be collected by the insurance company, the dental benefit plan, in administrative salaries, et cetera, et cetera. This was highly successful in Massachusetts. 72%, nearly 72% of voters, when it was put up to the vote, voted in favor of this, because I think it is shocking to most people to find out that a healthcare product has the ability to collect, say, 50% in premium and then, keep 50% of that. That's shocking to most people. And when they found out about it, they voted in a big way. So how does this benefit? It adds transparency, which I heard from the colleagues at NADP therefore. But establishing that minimum percentage, it holds the carrier's feet to the fire, and it requires carriers that do not meet the threshold to refund the difference. I'm going to talk about rebates in a little bit in the presentation, and I'm glad that NADP brought it up. So how does this help patients? It improves the value for employers and patients that they get out of their premium dollars. It makes dental insurance more reliable. It ensures patients get the care they need when they need it, and incentivizes dental insurers to cover the needed care. I talked about this last time, but just to bring it up for this body again, the current incentive structure for dental plans is out of whack. It is that if you de-incentivize patients from getting care, the insurers make more money. That doesn't exist on the health plan side. And there's a reason for that, because a health product is a little bit different. It should be focused on helping these people get the care they need. Incentivizing a dental plan to change a cost structure where they say the patient is responsible for 50%, and even adjusting that up to 60% would mean a great deal to somebody that has to get an extraction. It would mean they could afford it that year. That's what we want out of a dental plan. So I'm going to go through some responses that you heard some of these today, responses to the opposition for MLR. Number one, the claim is that the insured patients currently have excellent access to dental care. And Mike referenced that most people say, yeah, we're in favor of this. We want dental plans to not be a check the box and we've done enough. It is still, even if you have insurance, it is still too costly. It still costs people too much and they delay care. How can we change these products so they're focused on the patients, focused on getting them access, focused on getting them access to the care they need today? The claim is that a large portion of the dental premiums go to administrative costs, which is good for patients. Our argument is when too large portion of the dental premiums go to administrative costs, it takes away from the patient care. And Mike said that, we're for, it's a person, I think, stapling in the back room. And we know there's more to administrative costs. We're for administrative costs that make sense. We're just for more of those costs and incentivizing dental plans to become more efficient. That's what the ACA has done, and we're asking for that same thing when it comes to the dental plans. I'm going to talk you through some California data because we have it available. And I want to walk you through that because I think I want to address a couple of things. One is it would be impossible for the dental plans to meet this. That's not what's borne out by the data. And also, I want you to see that without something like the rebate system that exists, during COVID, dental plans collected premium and did not have to pay out in care. How do we alleviate something like that? So let's take a look real quick. This is in the large group market. And you can see there's a little grid down at the bottom where it's, if a plan is over 80%. You can see that a number of large employers are able to meet that. If a percentage, I will say to the members of this committee, if you'd like to see the entire scan of all the plans that were available in California, I can certainly provide that to you, just let me know. But this is just reflective of the fact that this is possible for the dental plans to meet. And it will not kill competition automatically. And shouldn't we incentivize these plans to be better? I frequently use this analogy, I'll do it again. This should be like fuel economy standards, where we're nudging dental plans in the correct direction. This is what this type of policy would do. Mike mentioned also that the small group is a little more, it's a little lower and difficult to do. Again, there are those that can meet it, and I would be very interested in talking with NADP about a tiered system where there was a different percentage maybe set for the small group market. Here's the averages of the California Dental MLR. You can see that dip down during COVID. Again, if there were a policy in place that was set up, that money would go back to the patients or whoever was paying the premium. That's why this is good policy. The other thing I will let you know is there are a number of, this is averages, there are a number of plans in California that have very low MLRs. And they really, could you even call them a true dental benefit plan? That's something this policy would also address. Finally, the claim that rebates are self-defeating and cost too much to generate. You know, I think that there are options for a state that's addressing this. They mentioned that the checks would have to be cut, the juice is not worth the squeeze, but what if it's a reduction in the premium that the patient has to pay the next year? You know, that makes it, again, that makes the dental benefit more affordable. There are policy or options, technical options that could make this amenable to all the parties involved. So again, NADP would like us to stop at the definitions and transparency here. But these, we feel, are the 4 essential components of an MLR bill. Good definitions, you know, making sure that this fits in with the statute that you're working with, good transparency, and that's where NADP would like us to stop. But a refund, a rebate, that holds people's, everybody knows about incentives here. If there's nothing that's going to hold you to the fire, you're going to get the California data again, which basically stayed the same in the 10 years that it's been there. Finally, a rate review and approval requirements. There was mention that the Milliman report said that there would be an increase in 38% for the small group market. Remember, in that same report, they said because of the rate review that's inherent in the ballot initiative, because of that rate review requirement that says that the dental plans rate increases are automatically disapproved if they go over dental services consumer price index. The Milliman report admitted that they could not, they didn't take that into account when they put out that 38% increase. So that's another essential component that we see. And I'm going to now turn it over to Dr. Flynn, he's a Minnesota dentist and joined me today. So thank you very much.
Thank you, Chad. As he said, I'm Dr. Flynn, and I don't have any slides. Isn't that nice? And I'm going to talk about your insurance. There's about 40 of you sitting around the tables here, right? And if you're the average citizen in Minnesota, I know 30 of you have dental insurance. So I'm going to talk about your dental insurance, okay? Now, the first thing that's been mentioned is the unusually low maximum annual payment. I think Chad mentioned $1,000, but $1,500 is common. I want you to think of what yours is, because I have dental insurance. I'm lucky my wife's working too, and she's the one that pays for it, along with her employer. And mine is one of the highest ones there is. It's $2,500. Wow, which is pretty good. But you think about your dental insurance, and you can tell I've been in this business for several decades by looking at me, all right? Back in the 80s, the maximum payments were about the same. I had $1,500 back in 1983. It's 2023, and we still have $1,500. Back in 1983, your preventative services in my office for the year, if you came twice a year, would have been less than $100. Today, they're $500. So you're losing on that maximum benefit. If you need any care, you're going to go over the maximum benefit, and it doesn't take much to do that. Now, the other thing I want to incorporate into this is the new technology we've had in the last 40 years. Wow, isn't it nice? Now, last year I cracked a tooth, and I lost the tooth because when you split the root, you cannot salvage it. So I had two options. I could do a bridge or I could do an implant. I chose to do an implant. And with my $2,500 maximum after my preventative services, it covered about 20% of my expenses. My point is we're behind the times on what we should be. If you go back to 1982 at $1,500 to now at $1,500, that would be $500 back then. Our inflation has gone up at least 3 times, if not more, even though our industry of dentistry has been one of the lower medical fields that has held a line on costs. We actually are very efficient at holding the line on costs. And again, if you're 2023, if you want an implant or if you need a root canal or maybe you need partials, dentures, crowns, think about your care, what you need. Isn't it kind of embarrassing that whatever you pick out of those major areas is only partially covered because you reached your max? So my position here is this has to change. We need to make the max higher. And I've heard that there's a lot of difference between medicine and dentistry. Well, there is in how we deliver. But we all know if you don't have a healthy mouth, you don't have a healthy body, right? Dentistry is not optional. It's not optional. If you want to live a wholesome life and a quality of life, we do know that all of our nursing home patients today, when I graduated, 40% had complete dentures, and today it's less than 20. Isn't that great? Which means we got to maintain the teeth they have for quality of life. So in conclusion, I'd just say, without a doubt, dental insurance will change to meet the current needs of our insured. And from what I've heard and what I watched on the slides, I don't see it's meeting the current needs. Outdated policies need to become current. I think having a standard like a medical loss ratio will help meet this need. I really do. Now, whether you're a dentist like me, basically retired from his larger practice for 5 years, or if you're a middle-aged teacher, bricklayer, cement worker, truck driver, pick your occupation, they want quality dental care. Quality dental care. They want more. They want adequate care and not just a minor supplemental benefit. And that's where we are right now. So my position is to change the way we're marketing our insurance rather than, again, I appreciate them trying to hold the costs down. Below inflation hasn't helped because inflation kept going. And now we have an opportunity to do alternatives. And if this proposal helps get you people where you need to be, now think about when you go to the dentist and what it costs you out of your pocket. You want real dental insurance, right? So that's what I'm promoting, and I want to thank you for your time. And I had a good time presenting this, and no slides. I hope you remembered. I know you did, because I was trying to watch that, and this is my trade. So if I can help and answer any questions, I'm here.
Okay, thank you for being here. So we do have some questions already. First, we have from Senator Hackett.
Yeah, thank you. I have a number of dental clients, and I would say to a dentist, when you ask them what the most important coverage that they have, they'll say the preventive. And, you know, they pay 100% of preventive, 80% of basic, and 50% of major. And so, and you ask them why is that the most important? Because it gets the people to go to the dentist twice a year. And then they find out and they save on cavities. They don't have as much cavities, and they make sure things are done, and they get the cleanings and the things are done. So when you talk to dentists, dentists, I would say many times, they're worried about driving people away from not seeing them, and if they don't be seeing them. So my big fear of this is, I agree with you. It's basically a preventive and basic plan. It's not even 50% by the time you get to it, you don't have that much left. So my question is, don't you think the number of people that go to a dentist and get under the plans will decrease if you offer much higher benefits at a much higher cost, et cetera? I mean, forgetting the emergency, the loss ratio, it's totally different. I mean, the key is you want to get people to the dentist. So when you ask dentists, what's the reason why you haven't had the big increase in the benefits? Because they don't want to drive people away from going under the plans and having those 2 visits a year. So that's a question.
Yeah, thank you. And so I'll let NEDP comment too, obviously, and Dr. Flynn. I would say my response to that is dental tourism is happening, and there's a reason it's happening. They're going to places like Mexico to seek care because it is too expensive. And I think that there is a real potential with a policy like that to change the paradigm without the severe reduction like you're saying. I don't think dentists are satisfied with the current crop of plans. They would like to see more. And I don't know if Dr. Flynn would like to comment on that, but that's what I hear at the American Dental Association, is that if there were products out there that supported more than just the bare minimum, it is good that people come to the dentist because of these products. I don't anticipate, and that's not what we saw in MLR on the major med side, I don't anticipate a real big drop in coverage. I'll also point out, and NADP can be specific about the numbers, but the number of covered lives for dental, by dental, has only shot up exponentially, even in the last 10 to 15 years. So if there is some sort of tailing off because the plans are not adequate, and then everybody adjusts because this policy takes root, and then these are great products nationwide, I think that's an overall good for Americans. So I don't know if
Yeah, but before the doctor, it says, doctor, my district is not a super affluent district. If you're a dentist in a high affluent district, of course the people will want better coverage. But if you're in an average district, you're going to drive people away from going to the dentist if you don't give 100% of preventive. You don't give them the incentive.
I hope I never implied that we didn't want to give preventative. My position was, in 1982 or 3, the cost of preventative care, meaning your cleanings and x-rays, was approximately $100. In 2023, we do want the preventative care, but it now costs about $500. So if you need something more than preventative care, you're really short. And they want better services. I do a lot of pain management, and when it comes to that, they might do there routinely, but you're going to have people like myself who chewing on something you probably shouldn't have been chewing on, split a tooth in the middle of the root, and I needed extended care. When we got to that care, I have one of the best plans in the state of Minnesota, and it's still only covered about 20% of it. And I'm saying that people today, they want better dental health, they demand it. The dental IQ now is way different than it was 40 years ago. They don't consider their teeth optional, they consider their teeth necessary. And they're going to do whatever they can to preserve their dental health. And sometimes that's more than preventative care. And I never saw a plan that came in my office that was, quote, just for preventative care. I mean, that's great. We want to get them in. But I practiced in a small town of 1,400 people.
Yeah.
I knew every one of them. Yeah, I sold hot dogs at the Booster Club. You bet I did. And yeah, I knew who couldn't afford care, and I knew who could. And I never kicked anybody out of my office that couldn't afford care. Now, I don't need to tell you I was the only dentist in town, all right? And you treat your community. Now, from what you said, I have a feeling your community is that same way. I bet they are. I speak of your dentist. Thank you.
Do we have future questions? Let's only have one person from each side talk, so we'll run out of time if we don't.
Yeah, and Senator, I can briefly respond to this from the plan perspective as well. I think you're absolutely right that preventive care is what keeps people going to the dentist, and we absolutely share the value that Dr. Flynn pointed out, that that is one of the most important parts of people's, continuing oral health, that they have access to a dental home. I will say from our plan's perspective is that when they are designing the products that they are giving, that they are offering to a small business or to an individual, that they want that emphasis on the preventive coverage, but also these groups or these individuals are coming with a budget of what is the type of plan that I am able to offer to my employees so that they have dental coverage. And in those conversations, particularly in the small group market, they are looking for a low premium that they can keep so that they can offer and people can maintain those coverage and they can get that preventive treatment. And that is first and foremost one of the most important things that the dental plan can provide for them. So we absolutely agree that our major concern is that if you see an increase in premium, I mean, the economics data is clear on this, that for dental plans in particular, people are extremely price sensitive on the premiums. That if they're, when they are shopping for benefits, they are looking for that premium in particular, and that's one of the key decisions that they make. And so our plans work very hard to work with those groups to say, what is your budget? What can we accommodate? What types of plans can we build for you? And that focus on prevention is always critical to those designs.
Okay, Representative Lehman. Where is it? There he is.
Thank you, Mr. Chairman. Just maybe some feedback or some comment on this is, I guess I've sat here and listened to this now for a couple of different sessions, and I think that I have family in the dental world, and they're saying it is causing some service issues because I may refer you to a completely different dentist because the reimbursement from the dental plan is less than my cost. So I'm not going to provide that service, and that's troubling. So I don't. But if we talk about medical loss ratio, is that the solution, pushing more money to the dentist? I'm going to go back to the ACA. I mean, the medical loss ratio is what everybody wanted in the ACA. I had 16 health insurance carriers I had in 2009. Now I have 2. So you are going to, if you push this pendulum too far the other direction, you're going to limit the amount of carriers that can be out there. So I guess I think moving forward, as we continue this discussion, I've heard Maine, I've heard these other places, are there ways that we can find this so we get more to the providers so that they are getting reimbursed for their services and not taking that loss? But secondly is not injuring the industry or putting them out of business, because we've seen what that's done via the ACA.
Yeah, and one thing I think I would add on to that is to elaborate a little bit more on the structure that Maine and Colorado have passed. Chad mentioned earlier the discussion of the California reporting data, which has been utilized since 2014. And it does show a spread of loss ratios in all of the different markets. But what we think is effective about utilizing the Maine language, or the language that was also passed in Colorado, which is very similar, is that it empowers the department to look at those plans and to say, what benefit is this showing, what benefit is this providing to the people who have enrolled it, and utilizing that data and making sure that it's specific to its state so that you can develop regulations that are going to be tailored to your state and to the needs of the plans and the individuals in your state, and we think that that's going to be the most workable approach.
So thank you for the comment, Representative Lehman. I think one thing I would focus in on is that you said something like more money going to the providers. And I admit that it would, but I think the more important thing to focus on is the buying power of the patient, the ability to buy the services that he or she needs. That's the real focus and why this is such an important consumer issue. And then addressing your comments on competition, I think there is some wiggle room, and this is something that I had talked a little bit with Delegate Westfall about, where you could have a covered lives limit, whereby if you had under that certain number of covered lives in the state, the medical loss ratio would not apply, and that would increase the competition, the ability of new entrants to come in. But once you'd gone over that threshold, then you would have to abide by that medical loss ratio. And again, this is nudging payers in the right direction, where they're incented to get the care out. Thank you.
We got 3 more questions and we have to move on. We got more agenda. Representative Meskis?
Yeah, I'd like to go back to the issue on, I think in covering insurance in Connecticut with my colleagues here, you know, a PBM, you can obviously hear what I said before in my affection for policy benefit managers. I think the medical loss ratio and a DLR are complicated issues. I can see that the biggest problem I have with a medical loss ratio or a dental loss ratio is it incentivizes the insurance carriers to increase prices. Because whatever you set, and I don't care whether the limit is 15% or 12% or 20%, on every dollar of premiums, I'm making 12 cents, 15 cents, 20 cents. So the only way I make money is an increase in premiums, which is driving the increase in costs. So I worry that the unintended consequence is going to increase the cost of service. It's also going to drive out a number of the insurance carriers because they're going to have that regulated framework. I'm not convinced that we get to the right level of practice. And I'm not sure we're in the crisis I'm hearing, other than the question is whether the policies and the demands of the public are to have larger premiums. So you can cover more expensive procedures in extremis. But I'm with my colleague that the first thing is preventive medicine, and I'm not sure that this is going to do anything to reduce costs. In fact, everything I see in the medical profession tells me it's been an abject failure in the MLRs because we have no control over costs in the medical profession. I mean, our insurance rates are going through the roof. It's becoming unaffordable. So it's not addressing my constituents' problems in the medical profession, and now I'm importing it into the dental profession where I'm not hearing the problem. I'm very worried about it. That would be, I don't know if there's a question there or a statement, but I don't understand how I keep control of costs under a dental loss ratio. And if I can't regulate it at the medical side, what makes it unique that I'm going to be able to do it on the dental side? Maybe you can explain what the difference is on the MLR versus DLR and how you envision it.
Thank you for the question and comments. So, and I would say, I would point you to that fourth bullet that I had, the essential parts, where the state had the authority to disapprove rates. And that's what happened in the Massachusetts ballot initiative. The state has the ability to disapprove rates. I do think, I understand the committee's, certain members of the committee's concern about competition and and wanting to maintain them. But I think that there's the ability of insurance companies that are staffed by a bunch of smart people to adjust and continue to offer products, I think is remarkable. And to see even the broad swath of carriers that offer in places like California, they will be able to adjust. And I'll also say, while there is some, as NADP indicated, some reduction in the number of carriers that may be offering in Massachusetts, I think we're going to have to see, we'll see probably that that is a very rich market. They will continue to offer coverage there. If it is applied to all, then all will adjust. Thank you. I don't know if you guys want to respond.
So I appreciate Mr. Olson's comments and appreciate the comments being offered by the panel here. First, just a couple of things. It's been discussed that establishing a arbitrarily determined MLR is a nudge. It's kind of pushing the market off a cliff as opposed to a nudge. What a nudge would be is more along the lines of what Colorado is doing, where there will be transparency, but on top of transparency, there'll be remediation powers given to the regulator. If there are outliers, the regulator can nudge the outliers. That's a nudge. Taking a number that has no history in the state and assigning it to the state is spinning a roulette wheel. There has also been comments made about the basic benefit structure of 180/50 and where annual maxes get set. Just note that dental plans, as Owen noted, dental plans talk to their customers, and dental plans are quite happy to sell more expensive products when there's a customer that wants to buy a more expensive product. There are plenty of no annual max group plans out there. They're not predominant in the market because most employers won't pay for them. But employers who want a no annual max product can get one. Employers who want a product where where unused benefit gets rolled over in the following year to compound the annual max next year, employers who want to pay for that get that. There are also dental plans that further incent preventive care by adding to the annual max the following year for people who are getting their preventive care appropriately. So a number of the comments being made about common or historically common benefit structures are in fact, there's a good deal of innovation in the market currently.
Two more questions, and we have to move on. Representative Ferguson.
Thank you, Mr. Chairman. Yes, it would certainly be my hope that if you have an MLR, that instead of necessarily giving rebates, as you pointed out, it might be expensive to send out by small carriers, that you could increase the dental benefit. In response to Representative Hackett, preventive is very important. Don't get me wrong, I guess I have a question for the dentist, but I would see people I'm a dentist, I would see people all the time in my practice, and they would come in and have preventive care, and you say, well, you need a crown on this tooth. Then their insurance was, they'd used up all their benefit for other things. It was going to pay very minimally, and you would offer all kinds of incentives to go in and get it done in payments, but then they would drag their feet because they would find other things more important than having dental care, and then they come back 6 months later, instead of a crown, they now need a root canal and a crown. So, it's not just about preventive, it's about being able to afford the care, and to hopefully the difference in the medical loss ratio you would make up in expanding the annual maximum or those kind of things.
Yeah, well, thank you for the question. I'll start briefly and then turn it over to the ADA.
Just keep it very brief. We do have to move on.
Yeah, of course. Yeah, and we absolutely sympathize and agree. Making sure that people are in the chair and getting the care that they need is incredibly important. I think really the difficulty of this, and where we see a mandated medical loss ratio coming into and becoming an issue for these people that may not be able to afford their care generally, is that even if in the circumstances that Chad discussed, where there may be a cap or an ability for a state to deny rates, we're already seeing in Massachusetts that means that those plans are potentially going to leave the market if they think that it doesn't make sense for them, or they're not even able to offer the plans that they originally have had in the state. And we know that means a perpetuation of issues for those people to be able to find coverage. And I think that our underlying concern is that in kind of setting a higher loss ratio that's not based on the data or the market within the state, is that you're going to see more of those plans leave, and that you're going to then have a cascade effect on people's oral health, and that they're not going to be able to get the coverage they need. I agree, and I think that our members and the ADA as well know that there's a broader conversation about oral health in the United States, and we know that dental coverage plays a critical role to that, but we just don't think that, as currently drafted, the proposal would make sense to meet those needs.
Well, I will say that, I hate for people to leave the market, but as with any insurance, it's only as good as it is when you need it. And maybe if those plans are worthless to start with, it's better they leave the market.
Just real quickly, I think that the goal, the reason this policy is such a good one to look at, and again, we urge your adoption with those 4 parameters that I outlined, is because this is about getting people to good oral health. And yes, a preventive-only plan, as Mr. Hackett put out, that would get people's butts in the chairs, but it does not get them to good oral health. And that, I think, is why this is a worthy policy for everybody to examine. Let's look at let's look at the value of these dental benefit plans and how to incentivize them to pay out the patient care that is needed. That's the opportunity here today, and I encourage you to endorse it. Thank you.
Last one would be Senator Gossage.
I'm sorry, I couldn't hear you very well. I think you said Senator Gossage.
Go right ahead.
Great. Thank you. Thank you all for being here, and I'm very anxious for us to be sure we have time for the other 3, so I'll be very brief. Some of you know I've been a health insurance agent for 20 years. I help write dental plans, but I often talk more people out of dental plans than buy them. And that's partially because they don't necessarily understand them, particularly employers, just how much is the premium, 40 bucks? Okay, I can do that. We'll have our employees pay 7, whatever that may be. But yes, they have options. You could have the $5,000 total out of pocket. You could have the $25. You can put endodontics and periodontics into basic and pay 80% of that. But the premiums are going to be a lot more. They just would have to be. And so most of the employers and most of the individuals don't choose that option, even though it's offered. I'm concerned, as was a colleague had mentioned, that oftentimes government becomes the problem rather than the solution. And if we were trying to do what happened with MLR is exactly what happened in my state. We went from 17 carriers to 3 when they implemented the ACA. And what I see right now is a vibrant dental insurance market. We have lots of wonderful dentists. I personally, for 30 years, have never had dental insurance. I just have a relationship with my dentist. He doesn't have to file insurance. He doesn't even take it. And then we can just work directly together. Do I think dental insurance is wicked? Not at all. I think this is an option that people can have, and we need to have these options. We need to have a vibrant market where they have a lot of different competitives, and we have that now. So I would not be in favor of a model legislation that would do MLR in my state. Thank you.
Okay, I want to thank all the speakers being here today. We will we'll be talking this up. We'll probably have an interim meeting sometime before our November meeting. Anybody has any ideas, suggestions, please reach out to me, reach out to the NCOIL Council. Hopefully vote on this in November or April. Next on our agenda is the consideration of NCOIL Hospital Price Transparency Model Act, sponsored by Texas Representative, the NCOIL Vice Chair Tom Oliverson, and co-sponsored by Kentucky Representative and Vice Chair of this committee, Rachel Roberts. You can view this model act on page 99 of your binder and on the website, on the app. We will be voting on this model today. I note that the American Hospital Association have been involved in discussion of this model act for the past several months, but they have declined to send a representative to this meeting. But it is also further, I will turn over to Representative Oliverson for brief remarks.
Thank you, Mr. Chairman and members. I'm very proud to sponsor this model alongside my colleague, Representative Roberts. And I also have to give a shout out to my colleague, Representative Meskers, who gave me the idea to introduce this in the first place by speaking up at this particular committee hearing a couple of NCOILs ago. So appreciate you both for your support in this. As you know, this is something that the feds have taken on, the idea that a consumer should be able to know in advance for a shoppable service what their insurance company is going to pay a hospital for a service that's elective, that's shoppable, that's going to be provided, and they ought to be able to shop around. We can do this in pretty much every single segment of our economy except for healthcare. And so the feds have passed rules on hospital price transparency, and what we saw in my state and what I think Colorado simultaneously saw was just a desire to ignore the rule. And so what this Model Act does, and what I think it will solve, is it actually increases the financial penalties on noncompliance to the point where hospital systems can no longer ignore what is already required by federal rule, and also simultaneously requiring that at the state level. And it does that through a series of escalating, what I call tiered penalties, where every day of noncompliance is compounded by an additional violation. And so essentially there's logarithmic growth in the size and scope of the administrative penalty that's assessed. And we felt like that's the best way to bring some of these extremely large tax-exempt, some would call not-for-profit, healthcare systems into compliance, because they were the bad actors by and large on this. While at the same time respecting that there are maybe small healthcare entities out there that don't have an extensive IT department and compliance may be more difficult. So our model actually takes that into account, and it creates a different tiered penalty structure for noncompliance based on the total revenue of a facility. We added to that some excellent language from our colleagues in Colorado, which actually would prohibit a hospital that is in non-compliance with this Model Act from being able to send a patient to collections for the non-payment of medical services that have been received. I mean, if you're not willing to show your prices up front, is it really reasonable to be able to send someone to collections and take them to court after the fact for something that you weren't even able to give them advance warning of what their out-of-pocket would be? So I think this is just a common sense thing. I think, you know, we've talked a lot about the cost of health care. To my way of thinking, transparency and pricing up front is literally the best antidote we have to the ever increasing cost of health care. And I do strongly believe that the average American, average citizen in our states is smart enough that given information about price in the areas, you know, places where they could go for services, that they will begin to shop with their feet. You know, they will select services based on what they can afford, based on what seems good to them. And studies have also shown that when patients are able to ask questions about price, and they start seeing price and they want to compare those prices, they also begin to ask questions about quality. And so that's something else that is sort of a hidden benefit by adopting this model, is that we actually arm consumers with pricing information which stimulates their interest in quality as well, which those are sort of, in my mind, the two legs of the two-legged value stool. So with that, I know we've got some people that want to comment on it, but I'm happy to take any questions you have, and I'm hoping that we can move for adoption.
Before we go to questions, we also have a few remarks from the JP Whiskey of the Council of Affordable Health Care Coverage.
Hi, thank you for having me here today. Briefly, the Council for Rural Health Coverage is a broad-based advocacy alliance with a singular focus on bringing down the cost of health care for all Americans. You may be familiar, we set this down. It's CTT is a campaign of CHC. We've been fighting for hospital transparency since our founding in early 2000s, and I just want to heartily endorse the bill. The work here to extend the Trump administration's rules and to ensure that there's compliance is going to bear fruit over time. And so we want to thank you for introducing it and give it our hearty endorsement, and we're happy to answer any questions. So thank you.
Okay, we do have a few questions. First, Representative Barhurst.
Thank you for this opportunity. We in Ohio just passed a hospital transparency bill, House Bill 49, off the floor about 5 weeks ago. It was bipartisan, 90 yeses, 5 noes. There was 4 folks that couldn't make it for different reasons, and I think I had 4 more yeses there. So we're going to get that over to the Senate this fall. But we did a simple codification of the Trump rule like you did, and we had 3 provisions of noncompliance. Says that there's no third-party debt collection allowed for 12 months, no credit score hit, and no private right of action to sue you for your assets to collect that debt. So, you know, the consumer and the patient does owe these bills, but we're just trying to give a timeout so they have time to if you weren't giving them the price, you got to give them the time to get through it. So I commend you on that, and our bill's based on the Colorado model more than yours. What I do like about yours is the total revenue and the penalty structure. Can you tell us how you're going to enforce it over there? We have a Department of Health and an oversight of the state auditor as well in there. And if we, some of the challenges we'll have in the next step is to clarify that, and I definitely want to be involved in that and get that done right. So I'd love to hear what you have to say.
Sure, and that's a great question. So we did spend a fair amount of time with our Health and Human Services Commission in Texas, making sure that they understood exactly what we were trying to do. It is simply written, but it's one of those word problems in math that really requires you to break out a pencil and a piece of paper in order to really understand kind of how it works, because of its stacking structure, where every separate day of a violation triggers a brand new penalty, which compounds daily. So, I mean, it really does increase over time like a pyramid. The reason we did it that way, quite frankly, is that the number one reason why the Trump rule was ignored for so long is just simply because the penalties were I mean, a fraction of even the daily revenue that the facility is able to get. And by sort of hiding behind this cloak of non-disclosure, it was a simple business decision. It's cheaper to pay the penalty than it is to be compliant and actually post your prices. And so we fixed that. So our mechanism for the largest over $100 million annual revenue cycle, I think that's the cutoff, but for the largest tier, you're talking about a multi-million-dollar administrative penalty that's assessed annually. And so we felt like that's really the size that was needed. Now, the way that our department decided to implement that in a way that was crystal clear to everybody, which I thought was rather ingenious, is they just gave examples, literally like algebra problems. They literally just said, so hospital A, is in violation and da-da-da-da-da, and here's how many days, and they just calculated it out in plain math so that there's zero ambiguity and everybody could see here's the situation. Now, you'll notice in the model that there are considerations, and in our statute as well, that good faith effort as far as compliance, trying to get their previous history of violations of this same chapter. These are all things that should be taken into consideration. One of the things that we ran across early in implementation with this law is that our law also is pretty aggressive in terms of looking at websites, making sure that you can get to it within one click from the homepage. And if you can't do that, then you're in violation. We didn't want this buried on some back page that nobody could navigate to. Our department was sending out letters of non-compliance based on the fact that they went to the website and they couldn't find it, not receiving a response from the hospital to their certified letter, and then just saying, well, see, this just proves that they're non-compliant because they never responded. So, I mean, there are some implementation challenges that go along with this, but so far it's actually worked well. In Texas now, we're over 80% compliant with the federal rule after less than a full calendar year of the implementation of this law.
Some of the surprises I had in this bill in Ohio is a lot of the smaller rural systems are actually, they were scared because the Trump rule and the penalties with that was significant to them. So I've got some of them fully compliant that I've met with and sat down with, and several of them are just a couple steps away. So let's say they're 80 or 90% compliant, and it's just the big ones that have literally done nothing and just laugh at you and say we're not going to. So that's the impetus of trying to do this. And then the one thing that we ran into is they created a complete confusion of what price transparency is versus what estimators are. Estimators are not price transparency. They have no binding. It's all full of small print. And don't let estimators get stuck in your argument as fulfilling compliance. And that's the part we've had to push back on the most.
I appreciate that.
Okay, we have one more question, and I'd like to go for a vote. We have Representative Cheney.
Thank you, Mr. Chair. Representative Cheney from Florida. This is just kind of a quick statement. We took a swing at this legislation last session. It didn't get through, but conversations are continuing. Part of the conversation we also included in this was requiring hospitals to identify themselves as hospitals, which seems crazy, but there's a lot of small hospitals popping up that look like these walk-in clinics. And so patients were going in thinking they were going to one of these, walk-in clinics and would get billing that way, and instead they would be receiving hospital billing. So something to consider.
It is interesting, Representative, that Colorado and Texas also share a distinction that I think we're the only two states that have the freestanding ER as well. And so that was another issue for us as to separate out and work through was, because a lot of these charges could concern services provided in an emergency room where the freestanding ERs, how are they going to be participating in this? That's sort of a constant frustration in Texas, is sort of the friction between the acute care hospitals, the freestanding ERs, the insurers, and unfortunately the patients that get ground up in the gears there. So I hope that you give it another shot. I'm happy to come help you.
Okay, so Okay, we need we are at the point to vote for this, so we need a motion to adopt. So moved. Have a second? Have a second. All in favor say aye.
Aye.
All opposed, nay. Ayes do have it. The motion is adopted. This will be brought up Saturday in the Executive Committee for final adoption. Next. Yeah, lost my part. Next on the agenda, consideration of NCOIL Biomarker Testing Insurance Coverage Model Act, sponsored by Newark Assemblywoman Pamela Hunter, NCOIL Treasurer, and Minnesota Senator Paul Uke, NCOIL Secretary. We will be voting on this model today. Before any further, I would like to turn over things to Assemblywoman Hunter for a few remarks.
Thank you, Chairman. I will be brief, as we've had a conversation about this bill for, I think it's been many, many meetings. I just wanted to add a few points and note a few changes to the model that have been made since we met last and since the conversation we had at our interim meeting. The model is in your binders on page 92, obviously on the website and app. As many of you know, I did pass a bill last month that I sponsored in my home state of New York that is based on the model passed with near unanimous support in both chambers and is now awaiting the governor's signature. This bill passed unanimously in the Senate and passed the Assembly by a vote of 143-2, and we have 150 Assembly members in New York. Also, after many collaborative discussions with the New York Health Plan Association, they did not actively oppose the model due to some amendments being made, many of which I have now included in this model, and I really thank them because they worked really hand in hand with me to make these amendments to get them passed in the state of New York. With this bill passing in New York, that marks 10 states, both blue and red, that have adopted similar legislation, and another 10 states have introduced similar legislation. So with this issue, we're certainly talking about a national trend that I think is important for NCOIL to be a part of. As you can see in the latest version of the model, I have made some changes, most of which aim to reinforce that the model is only meant to apply post-diagnosis. I know many see the word diagnosis in the model and it causes maybe some people some agita, but the language that follows of a covered person's disease or condition means that the testing is being conducted on someone with an existing disease or condition, not someone just walking off the street and ordering a test. In furtherance of the model only applying post-diagnosis, I have added language saying that, 1, nothing in the model should be construed to require coverage of biomarker testing for screening purposes, and testing is only meant to be covered when it guides treatment decisions and clinical utility. And taken together, both these amendments aim to make it crystal clear that the model is only meant to apply post-diagnosis to people with already existing diseases or conditions. And I'm going to stop there. I really appreciate everyone's work. Everyone's been really, really supportive. We know that this has been a hot topic issue, and I'm asking for all of your support in pushing this forward. Thank you.
Thank you, Assemblywoman Hunter. Before we go to questions, we do all with us today. I'm going to apologize for I butcher your name up. Hillary G. Gochner.
Very, very close.
Okay, of the American Cancer Society Action Network. Hillary, go ahead.
Great. Thank you so much, Mr. Chairman. I'd like to thank Assemblymember Hunter and Senator Utke for their support and leadership on this issue as well. I will be very brief. We've discussed this at length at previous meetings. This will allow more patients to access proven tests that are necessary to guide their treatment, improve outcomes, and often avoid unnecessary or ineffective treatments. We appreciate the amendments that have been made to address questions raised at earlier discussions. As Assemblymember Hunter noted, this is not a partisan issue. Many of you have supported similar legislation in your states already. This is now passed in 13 states, including many of those that you represent, and we urge your support. Thank you.
Okay, we'll now open up for questions with legislatures. First, we have Representative Lehman.
Thank you, Mr. Chair. I want to thank Assemblywoman Hunter for the changes. I guess my only concern is, do we have a clean version of that? I mean, I'm still looking at the model that's in the book, and I'm seeing, for the biomarker testing for the purposes of diagnosis, and I think you used the term post-diagnosis, and I want to make sure we're very clear that we're not talking about an initial diagnosis, but we're talking about after that. For example, if I go to think I might have cancer, I don't want someone saying, you know what, let's just do a biomarker test on you, not a biopsy. I think the whole thing of biotesting is once I'm diagnosed, there's different paths of treatment I can get. And I'm very supportive of that. I just want to make sure I'm very clear. My understanding, as you said, that this language will be in its final format, showing it as post-diagnosis. I'm referencing Section 3, Health Insurer Requirements A. The third line there talks about, shall include coverage for biomarker testing for the purpose of diagnosis.
What page you on, Representative? What page are you on?
93.
If I may offer a comment, diagnostic testing is a broad category that includes a lot of the biomarker testing that's used to guide treatment of cancer and other conditions. And so I believe from your comments, it sounds like the concern is about screening or looking for disease in an otherwise healthy person. And so that's covered by the language that was added about not being construed to require coverage of screening testing. But for a patient, one of the very common uses of biomarker testing is to subtype their cancer, determine which mutations are responsible for that. That would be considered diagnostic testing typically. And so we wouldn't want to exclude that and miss out on a lot of opportunities to get people on the right treatment early or avoid treatments that will be ineffective and have better, more efficient care delivery.
Okay, so I think you answered my question, but I want to make sure I'm very clear. If this were I'm not sure I don't have the New York model or New York bill in front of me. I don't know how this was worded in New York, but if I would use biomarker testing for an initial diagnosis, then I could make the argument this would require them to pay that.
So there are the purposes for when testing is appropriate, the diagnosis, treatment, ongoing monitoring of a disease or condition, and those are all, including diagnostic testing, are all included in the 13 states that have passed this to date. But there are also sources of evidence that must be met in order for a test to qualify, so being supported by nationally recognized clinical practice guidelines or an FDA-approved or cleared test. So this is something that's being done for a patient who's already in a provider's care for a disease or condition, as Assemblymember Hunter noted. And this is, maybe refining the diagnosis. There might be a suspected lung cancer, and biopsy tissue is sent for biomarker testing, which confirms an ROS1 positive mutation that's driving that lung cancer.
All right, again, I believe you've answered my question, but I'm still not hearing maybe clearly that there is no benefit for a first-time initial diagnosis.
I think it depends on the specifics of a patient and what testing is being done, but
Could you give me an example of where you
Sure.
would use a biomarker testing as the initial test to see whether or not I have cancer?
I think the question would be, is this a screening that someone is going for? So, are you going to have a screening mammogram or genetic testing to see if you're at risk for later developing a certain cancer? Or, there are early detection tests for cancers that are being developed. Those would be screening tests that might find a cancer diagnosis. But if you are having a biopsy done and for lung tumors, and that tissue from the biopsy is sent for testing, that testing may include biomarker testing that would confirm the suspected case of lung cancer because you have tumors in your lungs.
Okay. And that I have no problem with. I'm going back to, in lieu of
Yes.
a biopsy, I'm going to put you through some biomarker testing because Yeah, normally we'd do a biopsy, but, I'm going to bypass that and just use a biomarker test.
So many biomarker tests are actually done with tissue from a biopsy, and some are done with a blood draw. So there isn't a single way to do a biomarker test, but often it's actually done with that tissue from a biopsy sample to look for particular markers in cancer cells.
All right, and I'll leave it at that. I'm going to defer back to Assemblywoman Hunter. I trust her greatly with her post-diagnosis assurance.
Thank you.
Thank you.
Okay. Next one, Senator Lang.
Thank you, Mr. Chairman. I appreciate the opportunity to speak in opposition to this bill. I share Representative Lehman's concerns about the language is confusing, and I do appreciate the cleanup language at the back, but it still says health insurers, non-profit health service plans, and health maintenance organizations issuing, amending, delivering, or renewing a health insurance contract on or after the date of adoption shall include coverage for marker testing for the purposes of diagnosis. It doesn't get very much clearer than that. And if the goal of this is to get early diagnosis, I can appreciate that. In 2017, I was diagnosed with stage 4 colon cancer. It ended up being stage 3, but it was a 3-year battle for me. Had I discovered it in stage 1, my guess it would have been an inconvenience for me rather than a battle. So I appreciate the intent of doing that. But the reality of this is this. I still would not have gotten tested earlier. That's not who I am. I waited till it was laid in the process. 27% of people that have health insurance, 27% never use it. That's how health insurance works. There's a lot of people paying into the system that don't use it to benefit those 5% of participants that typically are 60% of the claims. So this is not going to change behavior. But what it will do, it will add costs to the system because it's an unfunded mandate. I trust free markets and free peoples to get it right. I wish the health insurers would offer this. Some of those will, some of those do. Oh, and by the way, in my situation, I had the coverage available because I'm under the state of Ohio's plan, which is governed by ERISA. But for those health insurance that want to offer this to small employers, they can price it into their plan, and those employers can then use that as an incentive when they are recruiting employees. We're going to give you better health care coverage if you come to work with us. So I trust free markets and free people to get it right. Another problem I have on this, guys, it's only going to affect our small employers, our pass-through entities. If you're a large self-funded employer, you come under ERISA. We cannot regulate you. A plan under ERISA can discriminate just about any way they want to, with the exception of discriminating in favor of the highly compensated employees. So we're going to pass this burden on to the small guys, the heart and soul of each one of our communities, the guys that are there for your charities, for your Little League. This is not going to affect the big guys. It's going to affect the little guys who are all struggling now with high inflation, with workforce development issues, with supply chain issues. These are the ones that are going to suffer. I trust the health plans to get it right. They will enjoy the benefits of good decisions or suffer the consequences of bad decisions, and I cannot support an unfunded mandate on the private sector. And I believe over time the private sector will handle this, and they'll handle this in a way that the sponsor of this bill, who I commend for bringing it forward, would like to see happen. I just trust the private sector to do it far better than the public sector, and I urge my colleagues to join me in voting no. Thank you, Mr. Chairman.
Yes. Representative Carroll.
Thank you very much, Mr. Chairman, members of the committee. I'm going to slightly disagree with my colleague from Ohio over here. I'm sorry about that. We actually did this in Illinois, and we were the first state to do this. And I will tell you right now that we saw some real benefits from doing this. The standpoint is that we're screening people early and finding out what certain things that they're dealing with are there. And it really offers technology to where patients can be matched with the right precision treatment without taking the shotgun approach. So I appreciate what you're saying, certainly, Senator, but I disagree, because I think the ability of us to know what we're dealing with can't just be a one-size-fits-all. We have to have specific things that come into place, and this is certainly one of those. So I'm very supportive of this legislation. And look, this will bring costs down. The cost of these tests are not astronomical in cost. So I do understand the unfunded mandate part of this, but I don't think this is an unfunded mandate that's as, is more tolerable, because the cost of this is not as high. So I'm very supportive of this. I hate disagreeing with my colleagues, but we'll get along into other things. But I think this is very important to the future of healthcare, and I stand in strong support of it. And I'd love to be a part of this, a sponsor of this bill if possible. Thank you.
Senator Hackett.
Yeah, thank you. And Matt, I'm really going to ask a little of Matt's question. A little more specific, and George, appreciate the good words. So I ask you the question. I'll give you a perfect example. It's breast cancer. So you have a situation where, let's say, you have one incident, your grandmother had breast cancer. And so you as a woman decide, hey, I'm going to go ahead. And even though the test comes back negative, you decide at that time to have a mastectomy, because you say it's cheaper and I'll go through less and I won't have the problems, et cetera. So I don't totally agree with that costs will always go down. And the problem is that we pass this to everybody. So we were told, Matt and I and other people were told, that yes, we were only if the person had a condition.
Yes.
Under that scenario. But that breast cancer, how do you answer that? Person doesn't have a condition. They have a family, someone in the family had it. So how would you respond? Because the way I read this, there's a lot of things that say that, but I don't like nationally recognized clinical practice guidelines.
Certainly.
That could be read. You look at Illinois, that's different than it is in Ohio, but go ahead.
Sure. So in that scenario, that would not be biomarker testing as defined in this legislation. That would be genetic screening that someone may go through, and that, depending on their family history, may already be covered to have that screening test to determine if they are later at risk. This legislation, I work for the American Cancer...
Why doesn't it say that it doesn't have genetic screening? Matt and I aren't attorneys. Why doesn't it not say that?
So that's one of the amendments that Assemblywoman Hunter added after the May discussion, was to say nothing in this legislation should be construed to require coverage of testing for screening purposes. So that excludes anything that would be about, yes.
Is it in here?
Yes.
Okay.
That would, anything for early diagnosis or risk. We love early diagnosis and detection, but that's not what this is about. This is about getting people connected with the right treatment for a condition or disease that they have. And so often in cancer, that means allowing people to avoid aggressive treatments or treatments that will be dangerous to them or ineffective, and avoiding trial and error with different chemotherapies that many of you may have experienced or known people who go through treatment after treatment trying to find something that works. And this provides more information to patients and their healthcare providers to match them with the right treatment. And these are, this is not 23andMe, right? This is sophisticated testing that's being ordered by a treating professional that went only when it is supported by these sources of evidence and for the purposes spelled out in the bill.
Thank you. Thank you.
Senator Theus.
Thank you very much. So one of the things I wanted to mention was that on page 94, section 3D and section 4D both have that comment that nothing in this section shall be construed to require coverage of biomarker testing for screening purposes.
Doesn't say genetic. I wish it say genetic.
What it would do is help to define what it is that they found in the screening, and then better aim the arrows at the issues that are there, particularly with respect to anything that is cancer related. But I have questions with respect to the statistics. Do you have, this is passed in multiple states already, do you have any statistical evidence, and I'm sorry if you presented that before, that speaks to the number of people that this change actually affected and what that cost looked like?
Sure. So unfortunately, there is quite a lag when the legislation is passed. It's then usually at least 6 to 18 months before that takes effect, and then another year or more before there's sufficient claims data to analyze. However, there is ample evidence of the benefits of biomarker testing when it's used for these purposes and supported by the evidence and the guidelines, allowing people to live longer and improving quality of life, and often significantly reducing costs by avoiding ineffective treatments or treatments that are completely unnecessary. So we have a volunteer in California who received a biomarker test to predict the risk of metastasis and recurrence with her breast cancer. Her insurance would not cover that, but she was able to pay $1,000 out of pocket to cover that, and that showed she would not benefit from further chemotherapy, and she was able to avoid significantly more expensive treatments by having that information and having the means to pay for that out of pocket or take the risk that insurance would not cover it.
Okay. Representative Ferguson. She's good. Representative Cheney.
Thank you, Mr. Chair. Myself and the state of Florida is not real keen on unfunded mandates, but having said that, my husband and I ran a mobile mammography business for 5 years and definitely have seen the benefit of early detection and the best technology that you can have for that, which I believe biomarker testing is. But to address costs, I was given some information by the American Cancer Society on tests, on studies that were done by CVS Health and Millman, and their projection is an increase in premiums of between 14 and 51 cents per member per month, and a savings of as much as $8,500 per member per month in total cost of care. Now, this is somebody who's obviously been diagnosed with the disease as a result of more optimal treatment, and that does not account for any potential cost savings from avoiding ineffective treatments, which was just addressed. So I just wanted to throw those data points out.
Okay, we got 3 more, then we will take this up. Senator Ellis.
Okay, well, thank you very much. I was the Senate sponsor of this biomarker testing bill in the Senate of Maryland. And I just want to say it passed in the Senate 46-0, very bipartisan, a lot of support. And it passed in the House of Delegates 132-3. And we worked with all the interest groups, with the Cancer Society and with our insurers and the drug companies. And it was a lot of work, but the model legislation here is very similar to what we ended up with in Maryland, which is a very successful model, and working with the Department of Health to fund it. So basically, this was not an unfunded mandate for us. We worked it out where everything fit perfectly into budget, and our insurance carriers were very supportive of that.
Representative Ryer. Representative Ryer.
Thank you, Mr. Chair. I am the sponsor of the bill that just passed in the Minnesota House, and in Minnesota, we are required to have an assessment done if we are possibly going to have a mandate added to our insurance package. So looking at the material that we received from the actuaries and from the team that did this analysis, the monthly expenditures, if you assumed 1.2 tests per 1,000 individuals, would increase monthly premiums by 1 cent per member. So clearly the risk of an unfunded mandate would be offset. The other thing I want to add that we haven't touched on is the impact of providing this coverage to address the disparities in healthcare outcomes. We know that Black and brown people in our society have much poorer access to healthcare, much less and much worse outcomes. So this is a valuable tool that we really have a responsibility, in my opinion, to be furthering and promoting. Thank you.
Okay, last, Representative Janae.
Thank you very much. First, I want to disabuse anybody of the notion that any woman is quickly making the decision to get mastectomies. As a survivor of breast cancer and have a bilateral mastectomy, it is not pleasant and it is very distressing to a woman. So I'm not worried that people are going to willy-nilly make the decision to get mastectomies. That being said, maybe prostates are more your speed. My husband was recently diagnosed with prostate cancer, and through biomarker testing, we found the right treatment for him, which meant that he missed no work, that he is already had his first PSA test that has shown a reduction in his cancer levels. And we know this because of biomarker testing. It's 2023. We have this amazing tool at our fingertips. Why should we not do everything in our power to make sure that our constituents get access to it as well?
Okay, and the last, a few remarks, Ms. Assemblywoman Hunter.
I'd just like to say thank you to all of my colleagues. This has been very thought out. The conversation about healthcare disparity is very real, and the conversations relative to quality of life when someone has been diagnosed with cancer or some other disorder, knowing that we want to be able to give them the best type of treatment possible. I understand the concern about business, and we're talking about finances, and we never want to be in a position to put any company out of business. We're talking about quality of lives for our constituents, our family members, our friends. My husband has had cancer. My mother died of cancer. Both my sisters have had cancer. I'm not, using this a tool for them, but for someone in the future, if this could give someone the best quality of life possible without having to, go through some treatments that, had you had a biomarker, maybe your life quality would be even better. We need to be able to work through that. So I appreciate all of my colleagues on both sides of the aisle for being very diligent and thoughtful about supporting this legislation. Thank you.
Okay, we got the motion before us. We do need a motion to adopt. Do we have a motion? Do we have a second? Second. All in favor say aye. Aye. All opposed, nay. Nay. The ayes do have it. I declare the motion adopted. This will be brought up for the Executive Committee on the final ratification on Saturday. The last of our agenda, and we're running late, is the introduction, the resolution dealing with the health savings accounts. We will not be voting on this today, but just brief introduction and further discussion at our next meeting. I recognize Senator Jerry Klein of North Dakota, NCOIL Chairman at Large, in response to the resolution for brief remarks.
Well, Mr. Chairman, very simply, this is an encouragement, an amendment to state law that's going to help ensure that when we adopt certain types of laws in our state, that they don't inadvertently cause people to lose their access to their health savings accounts. Several states have already carved out that particular portion, North Dakota included. But since our friend from the American Bankers Association has put a tie on today, I would, I would
Yes.
turn the mic over to Kevin McKechnie.
Thank you, Senator. Okay, Kevin, you got 60 seconds.
I only need 30. Thank you for having me. And now that the committee is tired, hungry, thirsty, and thoroughly upset, we hope you'll just introduce this and we can debate it over the course of the next couple of months. What it will do is your NCOIL's resolution on copay accumulators made that proposal HSA friendly. Senator Klein's proposal does the same thing to all the other state health benefit mandates. It's a coordination piece, and we look forward to discussing it with you.
Thank you. Do we have any more business for the committee? We need a motion to adjourn. We need a motion to adjourn. Second? Second? Okay, all in favor say aye. We are adjourned, but real quick, we will take a 6-minute break. We'll start at 4:10 on the Finance Service and Multiple Line Issue Committee at 4:10. Thanks, everybody.